ahead.
Yeah, great. Okay, so welcome everybody. I'm Tim Sladden. I'm an HIV advisor with UNFPA, working very much with key populations. And I want to welcome everyone to this initial call, setting up the community of practice for key populations under the auspices of the Global HIV Prevention Coalition. And UNAIDS and UNFPA are the Secretariat for the coalition, and we welcome you to this call. And it's a very exciting to be setting up this third community of practice. We already have one on condoms, and we have another group working with the national AIDS councils and commissions in countries. So we're very much looking forward to this really important community of practice on key populations. We're working in collaboration with Genesis Analytics, who are going to be coordinating this. And I've just handed over to Kerry Mangold to give us a few housekeeping information.
Thank you very much, Tim. Colleagues, in terms of the logistics and administration of this call is available in various languages. If you go to the bottom of your screen, there is a button where you can select which language you would like to listen to this meeting in. If you would even like to listen in English, please kindly select the English language. The others you can select if you would like real-time interpretation. Then secondly, this webinar has been set up such that the question and answer box will be used primarily to guide discussion and reflection. So please kindly put all your questions into the question box. The panelists will endeavor to answer the questions in the question box, and there is some time allocated for reflection and engagement during the agenda, where we can address any unanswered questions at that point in time. The presentation and the recording of this meeting will be circulated to the mailing list after this meeting, as well as any resources that have been discussed or presented on this forum. Tim, I think that's everything from me. Thank you.
Great, thank you, Kerry. So this is very much a scene-setting first call, and this is the second call. We had one earlier this morning where there were around 200 people attended, and I think we have over 100 people so far and growing, so a lot of interest. And I want to now welcome back several speakers for some introductory remarks. We're very grateful for you to come back and do it a second time. So first of all, we have Shannon Hayder, the Deputy Executive Director for Programs in UNAIDS, who will make some opening remarks. Shannon, please go ahead.
Great, thanks, Tim. And really, thank you to everybody who's on the call. It's definitely a privilege to be here with you, and I get the honor of opening, I guess, the scene setting. And so let me welcome all of you to the launch of the Global HIV Prevention Coalition's Community of Practice on Key Populations. In particular, it's going to be a really interesting community. I want to welcome country government focal points for key populations and HIV prevention. Key population community-led organizations at global, regional, and country levels. Colleagues from our international partners supporting key population responses, and colleagues throughout the UN family at global, regional, and country levels. We have all gone through a challenging 15-month period, and we're still amidst it. And so I'm particularly excited that with all the work everybody is doing, you took the time to join this launch event. As most of you know, earlier this year, the UNAIDS board adopted the new 2021 to 2026 Global AIDS Strategy. Its theme is End Inequalities, End AIDS. And some things about that strategy are really important. First, there is a strong focus on key populations across all dimensions of services, of rights, of community-led responses. Second, there are ambitious new targets that have been set for the AIDS response, including 95-95-95 targets for treatment, And I would point out, and I'll probably emphasize again, part of the importance of these targets is not just that they're from 90 to 95, but those 95s have to be achieved in every subpopulation that's highly affected by HIV. So that includes key populations. So the point is, you know, highly affected people hopefully will no longer get lost in the national averages with their failure to be served buried in the larger numbers. Second, the new targets include 95% of people at risk are accessing combination prevention. And third, they also include new 10-10-10 targets for addressing structural barriers and discrimination in the HIV response. And again, the targets are specific to each population for each of the 5 key populations. And the message of that is that it's not sufficient just to reach targets overall if those people, if the 5 key populations who are heavily affected across the world are left out of that reach. Globally, we know we haven't reached the HIV treatment, prevention, or rights-related targets for key populations. Prevention with key populations has fallen further behind. In fact, there's been no substantial reduction in new HIV infections among key populations globally since 2010. And this is because even though some countries, some places have made tremendous progress for key populations and with key populations, in other places, infections are increasing, the epidemic is growing. And when you average them out, that doesn't give us global gains. So we are at a time where several countries with HIV epidemics affecting key populations have showed that success is possible. In Cambodia, in Thailand, and Vietnam, new HIV infections have declined by more than 60%, 60, since 2010. In Portugal and Estonia, new HIV diagnoses among people who inject drugs have declined by more than 90%, 90, in just over a decade. And in all of those examples, that happened in the context of scaled prevention and treatment for key populations, community engagement and community-led vitality, and an improved policy environment. And so the tasks ahead of us to achieve this next 5 years of progress in all these areas are by no means easy. There is not a single sector or a single player or partner that can achieve them on their own. Certainly the United Nations alone can't do it. Governments alone can't do it. Communities and implementers alone don't have the resources to do it. And so that's why we believe we need to all come together and build country-led and community-led responses. The community of practice of key populations of the Global Prevention Coalition will be a platform, we hope, a platform to bring different sectors and different parts of the world together to share and learn, a platform for implementing the new global AIDS strategy as it pertains to prevention, and a platform to really unpack the specific needs of each key population in relation to prevention and HIV testing and treatment, rights, and removal of structural barriers. And as you'll hear from more of the speakers as we go through, we recognize that each of the key populations might need slightly different things on these issues. So I encourage you all to actively contribute to the discussions and exchanges, not just today, but over the upcoming sessions that are planned throughout 2021, to make this a strong and practical partnership that brings cooperation and change at all levels. So thanks for being here. And Tim, I will hand it back over to you.
Thank you so much, Shannon, for those context, really giving us a very clear overview of how the new global AIDS strategy is such a good opportunity for us to really focus on inequalities that affect all the key populations. We now turn for a perspective from governments to Ruth Masha. Ruth is the CEO for the Kenyan National AIDS Control Council, and I ask you, Ruth, to give some opening remarks. The floor is yours.
Thank you very much, Tim. Let me just make some few remarks on behalf of the NAC managers around the key population community of practice. First, I think as the NAC managers in the Global Prevention Coalition, the key population community of practice is a top priority for us. And it's indeed one pathway towards success of HIV prevention. It is also essential because we have positive experiences that we can exchange across the country, and therefore having a platform under which we can exchange views is a first step to enhancing cross-learning across the programs and across countries. We therefore welcome this new community of practice initiative, and we are committed to ensure that key population in all countries within the Global HIV Prevention Coalition
Ruth, have we lost you? I can't hear you anymore. It seems Ruth has a connection problem here. Just give it a couple of moments, see if she might reconnect. If not, perhaps we can invite her back if she's managed to reconnect later. And but last but not least, I will ask another Ruth to give the perspective from the key populations perspective. Ruth Morgan Thomas, known by many of us, the global coordinator for the network of sex work projects, and here representing all key populations for these opening remarks. Ruth, please.
Thanks, Tim. And I'm just going to do some scene setting in this opening before we get into the meat of the business. So I've been on the Global Prevention Coalition Working Group for 3 years now. And over that time, we've seen new infections among gay men and other men who have sex with men, people in prisons and other closed settings, people who use drugs, sex workers of all genders, and transgender people and our sexual partners continue to increase, and now accounting for 62% of new HIV infections globally. But there are significant differences between the regions. So 99% of new infections are amongst our communities in Eastern Europe and Central Asia, 98% in Asia Pacific, 97% in the Middle East and North Africa, 96% in Western and Central Europe and North America, 77% in Latin America, 69% in Western and Central Africa, 60% in the Caribbean, and 28% in East and Southern Africa. Key populations in every country around the world carry a disproportionate burden of HIV, and yet our population sizes are relatively small. We are at greatly elevated risk of HIV infection when compared to the remainder of the population in all regions and in all epidemic settings. And we've seen significant increases still from 2019 to 2020 data. So gay men and other men who have sex with men are at 22, rising to 26 times higher risk of HIV acquisition. People who inject drugs are 22%, rising to 22 times, rising to 29 times higher risk. Female sex workers at 21, rising to 30 times higher risk of HIV acquisition. Transgender women, 12, rising to 13 times higher risk of HIV acquisition. And people in prisons and closed settings are 6 times higher HIV prevalence than the remainder of the population. So we have much to do. And if we are to succeed, it's critical that key populations are considered experts in their own lives, and that key population-led organizations and networks are adequately resourced to play the central role in national HIV prevention responses that will be required if we are to succeed. And I'm going to hand it back over to Tim. Thank you, Tim.
Thank you, Ruth, for highlighting just how acute the persistent epidemics are within the key populations. And I mean, even in sub-Saharan Africa, as you say, the hyper-endemic HIV in sex worker communities and other communities, up to 70% of sex workers infected in some African countries. So, but this is where the global pandemic of HIV is in key populations. Unfortunately, we've lost Ruth Masher from the Kenya NAC, so I think we'll proceed. Maybe she'll be able to join and come back in later on. Now let's focus on to the core of this meeting, and I'll invite my colleague Elizabeth Benamar, who's the Global AIDS Coordinator for UNFPA, representing UNFPA in the UNAIDS Joint Programme. And Elizabeth is going to give us some of the objectives both of the community of practice and specifically what we're trying to achieve in this call. Elizabeth.
Thank you, Tim. And let me join the previous voices, really welcoming all of the participants on today's call and how pleased UNFPA is to be a part of today's launch of this global community of practice on key populations. So as alluded to by Shannon, we have a threefold objectives for this community of practice. First, we really want to have a safe space where we can have frank discussion on how we can accelerate programs. Second, we want to facilitate an arena where you can receive updates on global policy, latest guidance, implementation tools, and financing opportunities. And thirdly, we're looking at facilitation of peer-to-peer and country-to-country exchange of experiences in program development and implementation, monitoring and evaluation, and community engagement. But before we actually realize these and work on these, we wanted to have today's launch so that we could focus and bring everybody together on the same understanding and introduce you to how the community of practice will work, but also familiarize you with the new global targets, the recommendations which came out of the deep dive sessions, which were hosted by the Global Prevention Working Group, and also available guidance and tools for you to use. Now, we're sure and we're excited that everyone here is also going to be, I'm sure, dynamic and bring their lived reality both to this launch and also to the future meetings and discussions of the community of practice. And was also noted earlier, we just want to acknowledge that we know that there are complementary groups that are ongoing or emerging. There's the Global Partnership to End HIV-related Stigma and Discrimination. There's a young key population technical advisory group, which is being established from one of the recommendations of the deep dives. And there also are the other working groups and communities of practice that were mentioned from the Global Prevention Coalition. And our hope is that at the appropriate, there will be an appropriate degree of overlap and integration amongst the groups without duplication. So we will strive to do our best to ensure that that happens. And from the joint program of UNAIDS and the co-sponsors, I just want to say that we share the concern on the need for programming at scale. And we really look forward to learning within this forum and also improving our support to key population programming. And with that, I'll hand it back to you, Tim, as the moderator, and look forward to the rest of the launch.
Thank you very much, Elizabeth, for setting the scene of what we're going to focus on today. We're now going to turn over to a series of presentations, short presentations that will give us some background. We're first going to look at the new global targets for 2025 that relate to key populations. Then we're going to explore some of the recommendations that came out of the deep dive series last year. And then we will look at this community of practice and what we hope to achieve with it. And then we will open it up for some reflections, questions and answers. And I do encourage you again, as Kerry said, please use the Q&A function at the bottom of your screen to type in any comments or questions. It's a big group. We have 140 people online now, so we have to moderate this through the Q&A function as we don't have a lot of time for Q&A, but please do put in your inputs there. So now I'd like to turn over to Keith Sabin. Keith is a senior advisor with the Strategic Information Department of UNAIDS, and Keith is going to give us an overview of the new global 2025 targets that relate to key populations. Keith, please take it away.
Thanks, Tim. Have the next slide, please. And the next slide. So let me just start by recapping where we are. This is a look at the trends of HIV incidence among these 4 key population groupings. And what we see in the last decade is virtually no change. The figures that fall between the yellow hashed lines reflect that there is no difference over the past decade in HIV incidence among these populations. Even more worrisome, if that's not bad enough, we see that there is a distinct rise in incidence among gay men and other men who have sex with men. So whatever we've been doing, it has not been enough. Next slide, please. I think many of you have seen these donuts. They've been in the reports the last few years, and Ruth has just recapped the numbers, but they'll be in your slide set when you receive these. But I want to go to the next slide, which is a figure you have not seen. And based on this morning's discussion, I wanted to highlight the left-hand column of donuts. We receive a little bit of data regarding trans men or transmasculine individuals. And I was able to pull these pie charts together. We don't publish these because it really is based on very little data, but it does show that we do have some trans men showing up in the data. Their risk is relatively small compared to other groups, but it is not a zero risk, and it is a population about whom we actually know very little with regards to HIV status and use of services to this point in time. Next slide, please. And you've seen these as well before, so it's really for complete slide set. So the next slide. And here we just have a box plot of HIV prevalence among the different key population communities gathered by the 2 sub-Saharan African regions as defined by UNAIDS. And you can see in the text boxes, HIV prevalence among adults aged 15 to 49 came out at 6.7%, which would fall down here on the y-axis. So you can see the mean and medians, which are denoted by the X's, or the bars across these box and whisker charts. It's much higher than what we're seeing in the rest of the population. And the same is largely true in West and Central Africa, where the prevalence is 1.4% among all adults 15 to 49, which would fall right down here. Over the next slide, please. What we tend to see globally is that HIV testing does occur. It is taken up by many in these populations. They all fall between 60 and 70%. But as a reminder, most of the surveys from which these data are drawn are conducted in areas where programs are available. We tend to do surveys where we have programs. That gives us an evaluation of those programs. It does not tell us as much as we would like to know about HIV testing uptake among each of these different groups of people. Next slide, please. And I'm going to jump down a couple of slides in the interest of time. Can we, next slide? And so we'll stop here. This is just the uptake of prevention services. We like to think of this as combination prevention. It's not in the technical sense, but it gives you a sense of the distribution. And here we see female sex workers on the left and gay men and other men who have sex with men on the right, where we have some countries that are doing quite well in what is reported to UNAIDS in terms of contact with programs over the last 3 months. And we have other countries that are doing less well, shall we say. And the next slide, here we have men who inject drugs and transgender women. Again, we see some figures that seem a little bit out of the ordinary. So Panama suggests that they reach a very high number of transgender women. That's largely because it's based on program data. So people who are enrolled in program and are coming back repeatedly, they tend to retain people, but that doesn't mean they're reaching a larger part of the population. That's something we need to look into more closely. Next slide. We have other ways of looking at whether or not we're covering people adequately with prevention services. When it comes to people who inject drugs, we also look at the number of needles and syringes that are distributed per person who injects. And we see very few countries, most of which are Western high-income countries, that are achieving that level of coverage. The majority of countries fall in medium and low, and really too many are falling in the low coverage zone, basically suggesting that harm reduction programs that are distributing needles and syringes are not as widely available with the number of commodities that we would like to be seeing right now. The next slide. We do not receive much data on spending by country where we can actually disaggregate by population. But this is just one example. It's Myanmar's spending on prevention as a proportion of all interventions. And very little in a country like Myanmar, which is largely an epidemic among key populations, we only see a quarter of their spending on prevention services for key populations. The majority of that is for people who inject drugs, which is probably reasonably appropriate, but overall an inadequate distribution. Next slide, please. Now, as we begin to talk about targets, one of the challenges we will have in monitoring the targets is that we are allowing for the fact that there is choice to protect, in this example, let's say, a typical sex act. We accept that sex acts can be protected by condoms, they may be protected by PrEP, they may be protected by suppressed viral load, U equals U, or in some cases, people will use both condoms and PrEP. So in recognition of that, it will make our task to monitor progress more difficult, but it acknowledges the fact that we have to address there are many ways to protect oneself these days from HIV transmission. Next slide, please. Now, I don't want to go into this too deeply, but I think it's important to understand that the way the targets were set recognize that there are different risk strata, different levels of risk undertaken or confronted by different members of key population groups. And to that end, we will show targets for very high risk, and low and moderate risk. Next slide, please. And here are those risks, and here are those targets for, just for example, for condoms and lube use by those not taking PrEP. And then for condom and lube use among sex workers, because we would hope they're taking PrEP, although we recognize that PrEP uptake has been suboptimal until now. And then we've distributed PrEP use targets by those risk categories I mentioned in the previous slide. And that goes on. Next slide, please. And I would be remiss if I didn't mention that we've also established targets for social enablers. And these are popularly known as the 10-10-10 targets, that we will have fewer than 10% of countries with punitive legal and policy environments that deny or limit access to services, fewer than 10% of people living with HIV and key populations who experience stigma and discrimination, and then fewer than 10% of women, girls, and people living with HIV and key populations who experience gender inequality and violence. Next slide, please. If we achieve these, our modeling suggests that we will actually steepen the decline or speed the decline in both HIV infections and AIDS-related deaths through 2030. Just follow the blue hash line. That's in the presence of the 10-10-10 goals being achieved. Next slide. And then finally, I just want to point that our modeling suggests that we will need roughly a little less than $10 billion by 2025 just to achieve the prevention targets. This is only prevention targets among the different key population groups that I've enumerated here. And this is a combination of both overseas development assistance and domestic funding. But this is the amount of money we will need to reach those targets by our current modeling and projections. And with that, I'll close and turn it back over to Tim.
Thank you very much, Keith, for summarizing this essential data. We continue to be driven by the data, and I think UNAIDS, WHO, and other colleagues working on the surveillance and the targets and indicators have really shaped our response, and it's shown how essential it is to have these key population specific targets. And as Shannon mentioned at the start, we're not talking about a general 95, 95, 95 across the whole population. We want to drill into each population to achieve these specific targets for each population to ensure no one is left behind, which key populations so obviously have been. So I understand Ruth Masha of Kenya NAC is back online. Ruth, did you want to round off your comments? You were cut off earlier on. I'll just offer that opportunity.
Yeah, thank you so much. I'm not so sure why I got cut off, but I think it's just really an emphasis that this community of practice is welcome to the NAC directors. And I don't know at what point I lost the connection. I hope I'm still on now. Am I still on?
Yes, we hear you loud and clear.
Yes, so I don't know at what point, but basically I had just a few points, and one of the key pointers was the fact that most of the key population programs, especially for countries in Africa, are funded by external donors. And I was just making a point that as we do this community of practice, it's important for us to realize the cost of doing the key population programs and be able to provide the relevant platform for advocacy so that domestic resources are allocated for the key population programs, especially with the dwindling funds from the donors. I think the other point probably that I had wanted to reiterate is the fact that the addressing structural barriers, as alluded to within this community of practice, remains a very key area that I think will provide a good area for cross-learning across programs. And therefore, this is very important, especially for NAC directors that are involved in coordinating multi-sectoral actors and ensuring that the key population program is not only for targeting biomedical issues, but also addressing the wider structural issues. So the other probably important point that as NAC directors, we feel is that the importance of ensuring that the evidence being generated from key population program is not just evidence that is informing research, but evidence that provides the key recommendations that can be quickly translated into programming and policy issues. So with that, let me also just finally emphasize the role of ensuring the countries have strong decentralized programs for key population that are led by communities. And I think this is some part of what we would like to learn from countries that have succeeded to do so, and ensure that we are putting a key population program that is not just focused at the national level for the elite community members, but also looking at the ones we are leaving behind as sub-population being left behind by the geographical location that they are living in. So with that, I can just conclude by saying that we indeed are excited to have this component added within the community of practice, and we look forward to engaging with the team moving forward. And we hope that this will be sustained in the due course for us to be able to have a number of sessions that can adequately provide that cross-learning required. Thank you very much, and back to you.
Thank you, Ruth. I'm very glad we were able to hear your intervention. Some very key points there about the role that the NACs play critically in mobilizing governments and ensuring there is space for key population programming in the broader AIDS response. And again, reiterating what Keith was saying about the structural and social enablers, the new 10-10-10 targets, and really these are the hardest issues to work on, but can be some of the most impactful if we can change the structural barriers that keep back the response, and the stigma, discrimination, the violence, and the the laws that influence discrimination against key populations. We're now going to turn over to Judy Chang, the Executive Director of INPUD, the International Network of People Who Use Drugs. And last year we had a very rich series of webinars, the deep dive series on key populations. And there were many recommendations that came out of this deep dive series. And I don't envy Judy's task of trying to summarize them all, but she's going to do so now. So Judy, over to you.
Thanks, Tim. Also just share from the slide deck. So as Tim mentioned, these are a set of recommendations from the deep dive series on key populations. Next slide. So just to give a bit more background, the Global HIV Prevention Working Group decided to strengthen its focus on key populations in recognition that there was insufficient headway made on key population programming. We know many countries do not have population size estimates for gay and bisexual men, people who inject drugs, sex workers and transgender people, and therefore do not, and in addition, do not sufficiently resource, design, implement, or monitor key population programming. And I'm sure, as we all know on this call, we know that headway on HIV prevention cannot be made without this dedicated focus. So the 4 deep dive sessions that were held in 2020 and 2021, the first session was making the funding case. The second was to review combination prevention packages. The third was planning for a sustainable response. and 4 was adolescent and young key populations. So it's hoped that these recommendations and action points from the deep dives will be informing the community of practice. So next slide. So the first 3 recommendations that came from the first session on making the funding case were very much related to the Global Fund and the importance of meaningful inclusion of key populations within Global Fund programming and processes. We know that key population networks need to be involved in this decision-making because we know best which programs, services, and interventions are most relevant and where they need to be directed. And therefore, there need to be these concerted efforts to ensure that communities are involved in these decisions. And of course, along with that, key population-led networks need to be receiving adequate funding to effectively engage and influence decision-making. So next slide. So there was, oh, sorry, just the one before. So there's the need to earmark investments for key population programming and make sure that it's protected throughout the grant-making process. We know that many key population programming priorities often get allocated to the PAR, the priority above allocation request, and sometimes this means they don't get funded at all, which means programming and funding and allocation of resources do not get to where they need to be. There needs to be monitoring of investments for key populations and including monitoring of whether funding is reaching key population-led networks directly. And to also, of course, keep in mind the global aid strategy targets on community-led responses. So that of 80% of prevention services to be delivered by community and key populations, and 30% of treatment to be delivered by community by 2025. So the last recommendation in this series was just to stress the importance of continuing to maintain the disaggregation of data analysis by key population. So next slide. So the second session was on reviewing minimum combination packages. One of the recommendations was to ensure better coordination at the national level. The second was to do with the revision of the WHO consolidated guidelines, which I know WHO will go into further detail later. And also one of the recommendations to ensure we are looking at addressing gaps in policy and human rights. And of course, knowing that there are a myriad of social, economic, and structural barriers, including criminalization of drug use, sex work, sexual orientation, and gender identity. And we know that these stand in the way of successful HIV prevention programming. So next slide. To emphasize the continued importance of the implementation tools that were co-produced by UN agencies and the Global Key Population Networks. That is the IDOIT, the SWIT, the MISMIT, and the Transit. And that will also be discussed in another session, but just to emphasize the importance of strengthening country capacity around these implementation tools. To also look at producing or developing country guidance for prioritization of HIV prevention packages, and also to stress that the prioritization should be done in partnership with key populations. And the last recommendation was in this session was to balance between cross-cutting principles and approaches, that is, principles of human rights, including decriminalization and meaningful community involvement, and that these should be seen as a prerequisite for effective program scale up. So next slide. So this session was around making the case for domestic funding, and also, of course, looking at social and talking about scaling up social contracting of civil society organizations. But also there was discussion about, whilst recognizing that this is a goal, it's not always a panacea, and there are going to be particular challenges around ensuring funding for services of criminalized populations. And therefore that this must be augmented by dedicated funding streams for key population-led networks and programming, as well as ensuring funding for advocacy as well. Next slide. So this recommendation was around transition and to ensure that for countries undergoing transition, that there's a continued and critical role for bilateral and multilateral donors. We also talked about the importance of the brokering role of UN agencies between governments and communities, and that this brokering role should really be standardized. Of course, there was discussion around strengthening data collection, including at the subnational level, but also to ensure and support the development of shadow reports, particularly by community-led networks and organizations. And of course, also discussing how to mitigate the impact of COVID on HIV service delivery as well. So next slide, just the last session was a deep dive on adolescent and young people, and key recommendations were around stressing the importance of youth engagement and youth-led organizations in decision-making, the provision of financial resources, and capacity building for engagement in data gathering and research as well, knowing how far we are behind in terms of gender as well as and age, as well as gender disaggregated data. So just finally, the last slide, just to emphasize next slide. Yes, just to emphasize the importance of stepping up as a global community, and the need to be taking on and discussing these recommendations and action points, and using the communities of practice as an opportunity to do so, the importance of sharing implementation lessons, and also driving momentum on these as well, and that this will be necessary if we are to really make genuine progress on HIV prevention, and the critical importance of continuing, or the critical importance of prioritizing and centering key populations in the response.
Thank you very much, Judy, for an excellent summary. And it really was an excellent series, the deep dive. And I think, as you say, this will form a lot of the work of the community of practice. And I encourage everybody to consider these recommendations and see how we can operationalize them and implement them and then turn them into reality. Now we're going to look at just how we will do this, and Clemens Benedict, who's a senior advisor with the Prevention Secretariat in UNAIDS, will take us through this community of practice. What is it? What are we really talking about here, and what are we going to do with this community of practice? Clemens, please.
Thank you, Tim. Well, we've already heard from other speakers that we have more granular and more ambitious 2025 targets for the HIV response now. We have a large and actually growing share of new HIV infections being among key populations, 62%. We have a prevention coalition that is moving into a second phase in line with the Global AIDS strategy, and we have a need for intensified action actually to accelerate progress in countries in order to achieve this target. So business as usual will not help, and we need these communities of practice as one avenue among different ones to build momentum and develop a common understanding and capacity around key population responses. Next slide, please. So a community of practice is a group of people who share a concern or a passion for something they do and learn how to do it better as they interact regularly. And as part of capacity development initiatives to achieve the 2025 targets, the Global Prevention Coalition, in partnership with the South to South learning network is establishing this community of practice, complementing other activities that are already there in the coalition and in the South-to-South learning network. Next slide. So what is the overall goal of this community of practice? We want to build a community of like-minded people across different countries with a common goal around driving key population responses. And it's not just across different countries. As you have noted, it's really across different sectors. And what we have seen and what Shannon has said in her introduction, it's not a goal that we can achieve on our own. The new targets actually require governments, communities, and implementing partners and technical agencies all to come together and work together. And this community of practice shall also be a platform for this type of exchange. We want to build accountability for progress being part of achieving actually the goals set out in the global strategy and contribute to enhancing capacity around programming in the full sense, including services and structural dimensions. Next slide. So the outcomes here of the community of practice just provide more outcome or results-oriented language around what we want to achieve, enhanced evidence-based key population-led programming, strengthened peer accountability and problem solving, enhanced feeling of being part of a global community working together, and then the capacity strengthening dimension. Next slide. Communities of practice, as Tim mentioned earlier, exist already in the Prevention Coalition for NAC managers, which Ruth just introduced also briefly, and then we have one on condom programming, and in other areas, communities of practice are still in the planning stage. So this is the third one that we are launching. HIV prevention among key population is the third community. Next slide. What is participation and the audience of this community of practice? You have noted this is not a global forum. This is a forum with a country audience as its core focus. So national government program leads, whether it's NACs or ministries of health, national key population-led organizations, including the global networks that represent them, in-country networks and associations, key population-led implementers, other country-level implementers, often in the context of Global Fund and PEPFAR, but also other civil society implementers, and technical partners and experts at global, regional, and country level. But the focus clearly is a country-relevant conversation that we want to have in all the subsequent sessions after this global launch. Next slide. So what is the approach that will be used? So what will actually happen? So there will be online events hosted by the GPC Secretariat and broadcast to participants. Each session will, each meeting will actually cover 3 different dimensions or sessions: a technical session around a core theme, a session sharing a country experience on that theme, and then a session sharing a community-led experience. Sessions will include presentations, film, videos, so different multimedia approaches, country case studies, and clearly in the focus here, learning from good practice shared by countries, and then translation into different languages will be available just as for this launch. Next slide. The resources for this community of practice will be on the Global HIV Prevention Coalition webpage. If you go to this webpage, you will already find a lot of resources under the item for key populations. So if you select key populations, you will find global tools, but also a number of country example documents and additional good practices identified and discussed through this community of practice can actually then also be shared at the coalition webpage. Next slide. So what are the next steps in terms of starting up the community practice in country? We may have missed some participants among government, among civil society or other in-country partners. Please encourage them to actually join this community of practice by writing to us at the end of this presentation. You have our email addresses, so more colleagues can join this community of practice. Contribute success stories for sharing, and those could be presented at one stage. So those could be documents to be included on the web page. Those could be items to be included on the newsletter that will come with this community of practice, and propose additional topics for sessions and newsletters. We currently have 4 topics which will be presented at the end. If you have other suggestions and ideas beyond those 4 topics to be covered this year, please suggest them and let us know. With that, I'll hand over to Tim again for the next discussion.
Yeah, thanks so much, Clemens, for giving us that overview of what we're really trying to achieve here. And really, I'd encourage everyone to be active participators, to offer suggestions. We want to hear about your success stories as well as your challenges, so we can work together and collectively and exchange ideas for addressing some of the barriers and the issues faced by key populations. So really this is up to the membership how well this will work in terms of exchanging and contributing and participating. We have now set a period for questions and answers, or any comments that people have. I see that people have been putting their comments into the chat, and thank you to those members of the panel who've already responded to many of these. I haven't had time to look at the chat or the Q&A, so Kerry, is there any questions there you think we should focus on that haven't really been answered? Or is there someone else who's monitoring the Q&A?
Thank you, Tim. I have been monitoring it. I think there have been a number of questions around the targets and definitions that have been answered, but perhaps it just raises the importance of further discussion. Many of the other comments are for the consideration of the Secretariat of the Community of Practice to continue forward in further discussions. And I think perhaps something that is still coming is that, oh, my apologies, I've just lost my train of thought. Oh, sorry, what I was going to say, it might come in a further presentation, but there are many colleagues asking how they are able to contribute their own resources for dissemination through the community of practice. And so I'm not sure if perhaps Clemens may wish to respond to that, because of course I think that's one of the key values of this community, is to allow and enable cross-sharing of resources across the network.
Thank you. Clemens, did you want to comment on the further resources that there are out there in the communities?
Thank you, Tim and Kerry. Yes, so we already have a large number of resources on the Prevention Coalition webpage. So if you go to the link that we shared, you will find a lot of resources there. Additional documents can be shared with us. They would obviously be reviewed, because we want to ensure that good practices are actually shared and availed. So it would go under review, and then it would be decided, if additional documents can be posted through that web page. We can obviously informally also facilitate linking you to other countries, and documents can be shared through other informal means as well.
Yeah, thank you.
Yes.
This will be a growing repository, and as new resources may be developed or adapted and tailored in different countries and contexts, we will welcome to receive those and share them. So it's really a central place for sharing all of these resources. I think there's a very good comment here from Namada about the intersectionalities between the different risk behaviors. For example, some sex workers also use drugs, or people using drugs selling sex. Sex workers are of all gender identities. Transgender people often do sex work as well. So this is, these intersectionalities are very important, and it's about looking at very much people-centered approaches and tailoring individual approaches to meet an individual's needs. These are the services that we have to consider how these are tailored. So we will certainly keep that in mind. All of these very useful comments that we're receiving, we don't have a lot of time to go into everything now, but we will consider them all and provide further responses if they haven't been answered in this call, and incorporate them into the sessions that we plan to have going forward. So keep these ideas coming. They're very helpful in guiding and shaping this community of practice to make sure it's appropriate and relevant to people's needs and priorities. Kerry, were there any other, quickly, I think one more if there's any others, or we'll go on to the next session.
Tim, I think many of them are really just comments around what we may wish to focus on further rather than questions for immediate clarity.
Okay, well, we'll certainly take them all into consideration and look at how we can incorporate these issues into the community of practice. So let's keep going. We'll go to our next session, which is further looking at what resources we have. There are variety of tools and guidance and information. And I want to turn first to my colleague Annette Verster from WHO, who is working in the HIV, STIs and hepatitis section of WHO. If I get that right, Annette, I hope I have, or please correct me, who will give us first an update on the WHO guidance for key populations on HIV, STIs, and hepatitis. Annette, the floor is yours.
Thanks very much, Tim, and thank you all, especially the organizers of this great initiative. Really happy that this is happening and that we can all contribute to this. Yes, I will quickly guide you through the current and future relevant guidelines with regard to HIV and key populations. Next, please. And just to say that as WHO, we have been developing tools and normative guidance for the last 20 years, probably around a range of topics, starting on harm reduction, prisons, and then moving to sex work, MSM, and transgender people. And in 2014, we felt the necessity to consolidate all these guidelines and recommendations into the consolidated key population guidelines that look not only at prevention, just to make this very clear, because I realize that this is an initiative of the Global Prevention Coalition. But of course, when we talk about key populations, it's not just about prevention, it's also about improving access to testing and treatment and care. So in these guidelines in 2014, which were also updated in 2016, we promoted one package for all key populations and included, of course, some special considerations for various subgroups, but it was really about bringing the message that, in a way, prevention, testing, treatment are all very similar for everybody, and just to give this simple message of one package and and this package, I'll get to that later. I'll show you what it consisted of, and you probably may have seen it already. Was really still focusing very much on HIV and on providing health interventions, but also on modalities of service delivery, and more importantly, on structural interventions. The focus was on HIV, but there was, of course, also attention for comorbidities and co-infections, such as TB, hepatitis, mental health, STIs. Basically, we also try to consolidate relevant recommendations from other WHO departments, such as mental health and substance use, people working on STIs and reproductive health and rights, TB, etc. Next, please. So this is the package. And I always say this, you may have heard me say this before, but it was really for the first time in WHO that we positioned a set of enabling interventions as part of a public health response to HIV. So the enabling interventions or structural interventions, they're named here, were really key and like the key message of these guidelines. As you can see, the health interventions, they're very straightforward: prevention, harm reduction, testing, treatment, and comorbidities. But the message was really that if you do not address the structural barriers for key populations to accessing these services, then there's no point. So really, for the first time, WHO included non-health interventions into the consolidated guidelines and the comprehensive package. And as said, of course, there was also something on service delivery. Next, please. So the definition of key population, I think you all know this, but I personally always make the point to really point them out, because very often, for example, prisoners are forgotten. And in our messages, especially to countries, to really say, we're talking about men who have sex with men, people who use drugs, etc. And we do this, and these are key populations, and they're based on the fact that they have increased risk behavior or behaviors that put them at risk of HIV. But they also are at higher risk because they can't access services, or they're often isolated from services because of the criminalization of their behaviors and of other legal barriers, and because of stigma and discrimination, etc. And although other disease areas may have also other populations at increased risk, we have now in our new guidance that I will tell you about, decided that basically, if you look at STI, hepatitis, and HIV, very much the same people are at risk of these various infections. Next, please. So we are now updating these guidelines because they're 5 years or 6, 7 years old. And because it is really felt that although they have been taken on, and a lot of other work, I think, is following from these guidelines, both at the political level, but also at the technical level. It is also a really important opportunity to promote again the importance of these of focusing on key populations. And the current guidelines will not only focus on HIV, but also on hepatitis and STIs, because of the integration and the same behaviors that put people at risk, and also to make services that we hope to recommend, to make services more person-centered, that people do not have to go from one service to another in order to get their health issues addressed. And very often, as I said, the same risk are linked to similar risk behaviors. So it makes sense that when you go to a clinic, that you're not only tested for HIV if you inject drugs, but that you're also tested for hepatitis C, for example. And if you're a sex worker, that you're not only your HIV status is looked at, but also if there are perhaps STIs, if you have STIs. So the idea of these guidelines is more integration and also to simplify them, to really focus on the most important recommendations, and to split the comprehensive package back into separate packages again for each population. And there will be a lot of overlap and similarities, and it's not that the interventions or the services are very different, but they might be different in priority. So for example, people who inject drugs, as I said earlier, the first probably issue to address is hepatitis C rather than HIV, and STIs maybe coming way later. And likewise for MSM or for sex workers, addressing STIs will be a higher priority than in other groups. Next, please. So a few areas that we will address. So first and foremost, the structural interventions will be, or the enabling interventions to address the structural barriers will be again at the front of this, of the new guidance. And at the health level, the health interventions, here you see a list of some new areas that we will be looking at. For example, chemsex, behavioral interventions, because we see that a lot of funding goes towards behavioral interventions, while they're not always that well defined. So we're really looking into that. And then with regard to service delivery, to look into the importance of peer navigators, for example, to support people navigating the health sector, to go from testing to treatment, for example, and also to look into virtual platforms for all types of services. With regard to hepatitis and STIs, perhaps you're a little bit less interested in, but still, for example, particularly MSM and people who inject drugs, to look at how frequently people should be tested when they have ongoing risk, and to provide immediate treatment rather than waiting for disease-specific outcomes. Next, please.
Annette, sorry, we're running over a bit. If you can round off soon.
Sorry. Okay. So just to say that in these guidelines, we're working together with the 4 global networks of key populations, and they guide the work on surveying the values and preferences of their communities is a very important part, both on the new recommendations, also on the structural barriers. Next, please. The guidelines will be launched towards the end of the year, early next year. Thank you. Next, please. And the derivatives of the 2014 guidelines, there are a lot of annexes. For example, there was a target setting tool developed as an annex, and also a set of technical briefs around what was specific with young and adolescent key populations. Next, please. Just a list of relevant tools and guidelines that you may find interesting, and they're hyperlinked. So once you click on them, you get them. And the next one, please, the last one, other useful websites. And I just want to say that, of course, countries and also regions have worked on guidelines and on strategies with regard to key populations. And I wanted to highlight also the ones of the South African Development Community, SADC, and WAHO, the Western African Health Organization, have specific key population strategies. That's it. Thanks very much for your attention. And if there's anything I can comment in the text box.
Thank you very much, Annette and colleagues, for so much expertise is put into these tools, and how they're updated regularly is really very, very useful. Now we're going to look at a further set of tools that'll be known to many of us here, the key population implementation tools. And Andrew Spieldener, who is the recently joined Executive Director of Impact for Global Action on Gay Men's Health and Rights. Andrew will just give us a very brief summary of these important tools. Andrew.
Thank you, Tim, and thank you everybody for attending. I'm very excited to be here. I will be talking about the key population implementation tools. As Judy mentioned, there are implementation tools across all key population networks. Next slide. So what are they? These are tools that were developed by the key population networks in partnership with WHO, UNODC, UNFPA, and UNAIDS. And we look particularly at how to really implement high quality key population programming. So each of the implementation tools has a different focus, and they're community led. And it's important that we stress that because it really goes deep dive into what we know and understand about our needs, challenges, and opportunities in HIV. Next slide. So what sets the implementation tools apart? One of the things that is very clear to us as key population networks is that we view HIV risk and vulnerability in the context of community. So while health access and equity is highlighted across key populations, we also talk about social and structural marginalization, including violence, criminal and punitive laws and policies, stigma and discrimination, and economic conditions that can really frame the way that risk and vulnerability is managed in the HIV response. We definitely see how our interventions that we put forward look not only at HIV prevention and treatment, but also harm reduction, social protections, community mobilization, and advocacy. Next slide. So how can you get them and how can you use them? I want to point out they're available at all of our websites. I'm actually going to, I've sped up my presentation in order for time, but they're easily available on our websites. You can see all of our organizations listed there on the slide. And go to our websites, download them, reach out. We provide technical assistance on using them, and we look forward to hearing from you. Thank you.
Thanks very much, Andrew, for speeding through which there are considerable, significant documents with a great deal of detail. So we appreciate you highlighting these key documents for shaping, working with key populations, putting communities, as you say, at the center of the response. We're reaching near the end of our session today. We've tried to cover a huge amount, so bear with us. We just have one more session and then we'll round off. Lulama Lunika, who is with the South-South Learning Network, is now going to give us a little overview of our future plans for the rest of this year and how we see the community of practice activities going forward. Lulama, please give us an overview.
Thank you, Tim, and good evening, colleagues on the call. For some of you, it's morning, so good morning to you. As Tim mentioned, I'd like to touch on what's coming up next and what to expect in the community of practice for the rest of the year. For some reason, other slides. There we go. The following topics have been identified for future webinars. And as you can see, the first really topic has been covered today, which is to introduce the community of practice to the members of the call. Would like to continue to explore, what it takes to build a strong foundation for scaling up impactful programs and how to address structural barriers to scale up access and services to key populations. We'd also like to look at how to measure and monitor key population programs, and finally, how to finance and sustain key population programs within the country's HIV responses. And so these are the topics we think are key and would be most useful for members on the call. However, these are still very much in draft phase, and we're still open to feedback from the members today. So please feel free to share a topic that you might have in mind, or anything you feel will not be covered in these sessions. So we're more than happy to revise this list or to add new topics. Secondly, we will be sharing a quarterly newsletter, which will share news, publications, and events planned related to key population programs. And the idea is that we hope that this newsletter will aid in improving access to community of practice members to new tools and trainings and sessions that will help improve programming with key populations. As Clemens mentioned earlier, that we're also open to receiving documents with documented best practice, any guidelines or case studies that you'd like to share with the community of practice. You are welcome and free to share these with us, and we will ensure that they are accessible to the wider community. I've provided my email address there at the bottom, but essentially anyone from the South-South Learning Network, you can feel free to reach to, as we have been identified to support this community of practice administratively. So I'd like to welcome everyone to share documents. Thank you, Tim.
Thank you very much, Lulama. That's great to give us a feel of how we want to be take this forward and the concrete activities that we're going to engage in. And again, we encourage everyone to suggest items and topics or issues that you want us to focus on that are relevant for key populations. We're coming up to nearly to the 90-minute mark. We've covered a huge amount. We have had many good comments into the Q&A. Thank you for all of the contributors there. I would just like to give the panel, any panel members, any very quick reflections from what we've heard and read during this session. Is there anybody from the panel who would like to make any closing remarks? If there are
maybe
none,
just to thank you all, Tim. I would really
yes,
like to thank you and UNAIDS and you as a chair, excellent chair, to kick off this this very first event. And I look forward to continuing the next and be part of this. Thank you so much.
great, Annette. Thank you so much. Well, we've had about 150 people on this call, and there were about 200 on the first session this morning, so that's 350. And I don't think that's everybody. So please do reach out to further communities and partners. We need, really, this is a partnership. We need academics, we need community members involved, we need governments and national AIDS councils and ministries of health and other ministries, development partners and donors. As I say, it really is a key effort. And so really it falls to me now really to thank all of our panelists who've gone over all of the details today and given us a scene setting and introduction, a lot of things to think about. And we really appreciate the South-South Learning Network for your guidance and coordinating this and as working as a partner going forward. I want to thank the interpreters. I know I've spoken rather fast at times, and we really appreciate your efforts to broaden the audience that can participate through the interpretation. The Global Prevention Coalition Secretariat, thank you very much for initiating this and driving this forward. And we look forward to engaging any community of practice is as good as its members, how active they are. So I encourage you all to participate. And just finally, many of you know we have the high-level meeting on HIV and AIDS this year in the UN General Assembly. There will be another political declaration that's being drafted now. We have made every effort to try and ensure that key population issues are central on the table for this discussion at the General Assembly. As we have seen, these persistent epidemics and the discrimination against key populations mean we have to increase our efforts and really find ways of implementing and going to scale and addressing the structural issues and social barriers. So this community of practice will be the forum in which we can identify what is going to work and how we can go forward. Thank you all very much for attending, and look out for our next steps as we take the community of practice forward. Thank you all very much.